Okay, so this is a lecture. The title on your syllabus is Problems of Pregnancy and Delivery, Part 1. There are two parts to those topics, and what I've chosen to do is pick what are the most common and I think most important issues that you're going to encounter on labor and delivery and talk in detail about those topics rather than trying to cover all the various different problems of pregnancy and delivery that you might encounter. So today in this podcast, we're going to talk about obstetric hemorrhage, and the major focus of the other talk will be preeclampsia. So obstetric hemorrhage, very important for us as anesthesiologists, even here in the United States, because even in the developed world, as a place like the United States, it continues to be one of the leading causes, the 5th leading cause of maternal mortality. And when you look at poor outcomes, at the ASA closed claims study, which looked at obstetric claims over several years, they found that among claims that in which there were rulings or money paid out for either maternal death or maternal brain damage, that obstetric hemorrhage was the 2nd leading cause, and that was oftentimes due to inadequate cerebral perfusion due to hypotension or maybe even cardiac arrest as a result of obstetric severe hemorrhage. In the developing world, obstetric hemorrhage continues to be the top cause of mortality. They don't have the resources that we have here, and it is the number one reason why women in the developing world die from pregnancy. Now, in the UK, where they have a confidential inquiry into maternal deaths that they report on and publish every 3 years, they have had some success in terms of improving their management of obstetric hemorrhage, in that the last report they found that obstetric hemorrhage had dropped down to the 6th leading cause of maternal deaths in the United Kingdom. Now, another important thing, though, when you look at that UK confidential inquiry into maternal deaths, when they look specifically at maternal deaths where it was determined by those who reviewed the records that anesthesia, at least to some extent, contributed to the death, more than 50% of anesthesia contributing deaths involved obstetric hemorrhage. So we're going to talk about the most important or the most common etiologies of obstetric hemorrhage, and you need to first divide it into antepartum hemorrhage and then postpartum hemorrhage. And what we're going to focus on antepartum are the placenta previa, placental abruption, and uterine rupture, and postpartum going to mostly focus on uterine atony and abnormal placentations, which is a growing problem here in the United States. So placenta previa, as I'm sure you all remember, is when the placenta lies over or near the cervical os, and as the uterus contracts and the fetal head starts to descend, that head is obstructed, and the contractions and the fetal descent results in hemorrhage due to the fact that the placenta begins to tear off the decidua. There are different types of placenta previa. You have a total or complete placenta previa, a partial placenta previa, and then a marginal or sometimes a low-lying placenta. How common is placenta previa? It complicates about 1 in 200 pregnancies, but it depends on the patient. And on those women who've had a previous previa in another pregnancy, the incidence for a previa in the current pregnancy is increased by about 12-fold compared to patients who have not previously had a placenta previa in another pregnancy. There are other risk factors, those who are multiparous, advanced maternal age, and those with previous cesarean delivery all are at increased risk for developing a placenta previa. So in terms of the signs of placenta previa, the classic description is that it is painless vaginal bleeding. Now, I will caution you, though, that there is an association between placenta previa and placental abruption, so that about 10% of women with placenta previa will also have placental abruption, in which there may be pain associated. Diagnosis is pretty much always made by ultrasound with the high fidelity ultrasound equipment that's now available. It's very accurate in terms of establishing the diagnosis of placenta previa. In terms of the anesthetic management of placenta previa, you're always concerned for the potential for significant hemorrhage. pretty much nearly all these patients will require cesarean delivery. Anyone with a complete or partial placenta previa will absolutely be delivered by cesarean delivery. Occasionally, you'll have an obstetrician who will attempt a vaginal delivery with a marginal previa or low-lying placenta. These patients, if you see someone presents to labor and delivery with a previa, this is the sort of patient you definitely want to see early, get an anesthetic evaluation, because even if they're not bleeding currently, if they start contracting, the uterus gets active, you may start to see bleeding. You want to have large bore venous access and definitely a type-in screen, and if it's looking like they're beginning to bleed significantly or they're going to proceed to delivery, a type-in cross. In terms of your anesthetic technique for the patient presenting for cesarean delivery with a placenta previa, it's going to depend on the situation of that patient. There are many patients with placenta previa who can have their cesarean delivery done under regional anesthesia. That would include those who come for a scheduled C-section. They're not currently bleeding, but they're now at 36, 37 weeks, have a known placenta previa, we're going to get mom delivered, absolutely do regional. If you've had a small to moderate amount of bleeding and mom is hemodynamically stable and baby's looking fine, it's also reasonable to do regional anesthesia in those patients. There will be some patients, though, who may require general anesthesia. Those who are having significant hemorrhage such that there's maternal hypotension or instability, or there's signs of fetal compromise as a result of the hemorrhage, those patients will require general anesthesia. And in this situation, if you're doing general anesthesia, it's generally because you have severe hemorrhage with maternal instability, and so your induction agent of choice is going to be a drug that's going to do better at maintaining hemodynamic stability, so you would choose drugs such as Atony or ketamine rather than propofol. Now, another common antepartum cause of obstetric hemorrhage is Abruptio placenta or placental abruption, and this is where the placenta, usually implanted appropriately in the fundus, begins to separate prematurely. In terms of its presentation, it's quite different from that of placenta previa. Classically, they'll have abdominal pain. The vast majority will have vaginal bleeding, but with a placental abruption, in about 15% of cases, rather than having vaginal bleeding, they will develop a retroplacental hematoma, so the bleeding is concealed. Those patients tend to not do quite as well because we oftentimes underestimate their blood loss and maybe do not resuscitate adequately. In addition to the abdominal pain, the classic presentation of a placental abruption is increased uterine tone, where the patient's having tetanic contractions. You put your hand on her belly and it's rock hard. And because the placenta is separating, you then are decreasing the oxygen delivery to the fetus, so commonly you will see signs of fetal compromise, or even occasionally with a severe abruption, the patient presents and already has an intrauterine fetal demise. In terms of the epidemiology of placental abruption, about 0.5 to 1% of pregnancies in the U.S. are affected by abruption. Patients with placental abruption generally do not do as well as those with a previa. Maternal morbidity and mortality is higher, and the morbidity and mortality does correlate with the severity of the abruption. In terms of complications that are commonly associated with a placental abruption, DIC is a concern. It is actually the most common cause of DIC in pregnancy, and it affects about 10% of all abruptions, and the more severe the abruption, the more likely that the patient will develop DIC. Patients who have either fetal distress or fetal demise are at increased risk for developing DIC, and that is because it's obviously a more severe abruption if it has led to compromise of the fetus. Women with abruption also are at a higher risk for postpartum hemorrhage. Overall incidence is increased about 2 times compared to the normal pregnant patient. If the patient develops DIC, though, the risk for postpartum hemorrhage is even greater. And in a small group of patients with placental abruption, those with severe abruption, significant hemorrhage, inadequate resuscitation, they can actually develop acute renal insufficiency in about 1 to 4% of cases. Now, the fetus in the setting of placental abruption also does not do well. And in fact, morbidity and mortality for a fetus in this setting is higher than for the mother. About 12% of all fetal mortalities in the U.S. are associated with placental abruption. And if you have a large retroplacental hematoma, you can see fetal mortality as high as 50%. Oftentimes with abruption, this requires preterm delivery. So about 40 to 60% of preterm deliveries are associated with abruption. And then, of course, there are morbidities to the fetus or to the neonate associated with being born preterm. Even term babies have a significantly higher risk of mortality compared to term babies born via a normal pregnancy, as much as a 25-fold higher increased risk of mortality. And there's also an increased risk of cerebral palsy in babies who have had a placental abruption. And again, this is not surprising because you expect to have compromised oxygen delivery and fetal hypoxemia with separation of the placenta. So who's at risk for placental abruption? There are several risk factors. Hypertension, be it preeclampsia or chronic hypertension, cocaine users, smokers, older women, those who've had PPROM, multiple gestations, those with trauma to their abdomen, thrombophilias, and if they have a previous history of abruption, they're more likely to have abruption with subsequent pregnancies. In terms of the anesthetic management of placental abruption, this is going to be determined by maternal status. If you have mild or moderate abruption, this will not necessarily be a delivery via cesarean delivery. So the first thing you need to know with a mild or moderate abruption is, what is the OB's plan? Are they going to attempt a vaginal delivery? Even if they're going to attempt a vaginal delivery and mom is stable, you need to understand that whenever you have an abruption at any time, that separation can progress and you get additional bleeding, so you always want to be ready with large bore venous access, blood available. Because of the risk of DIC associated with placental abruption, I think it's mandatory to assess coagulation status, not just platelet count, but PT, PTT, fibrinogen before proceeding with regional analgesia or anesthesia in these patients. But if coagulation studies are normal, mom is hemodynamically stable, there's not a lot of bleeding going on right now, and they're planning for vaginal delivery, it is definitely reasonable to do neuraxial analgesia. In terms of a severe abruption, this will generally require emergent cesarean delivery, either because the baby is having significant compromise, or there is instability in the mother. And these are things to keep in mind when determining your anesthetic plan. And in most severe abruptions that require emergent cesarean delivery, you will not be able to do neuraxial anesthesia for the fact that you either have a baby in distress, or you are concerned that the patient may be developing DIC, or that the mom is unstable hemodynamically due to hemorrhage and hypovolemia. Obviously, large bore venous access is necessary. In an emergency, you're not going to take time to place an arterial line right away, but you might consider, as things go along, place an arterial line, especially if the obstetricians do seem to identify that there's a coagulation problem and they're having continued significant blood loss after delivery. Now, in some situations, you may have a woman who was on labor and delivery, laboring with an epidural, who then began to have an abruption that was severe enough to require emergency delivery. In those situations, if you already have an epidural in place, then certainly it would be acceptable, if mom is hemodynamically stable, to go ahead and use the epidural for your cesarean delivery. Now, if you do require general anesthesia for your emergency delivery due to severe abruption, your induction agent is going to be based on your patient condition. In most of these cases, you're going to have some component of severe hemorrhage, instability, and so etomidate or ketamine, which are more likely to maintain hemodynamic stability, are usually going to be your induction agents of choice. In choosing one of those two drugs, remember that many of these patients already have significant increase in uterine tone with tetanic contractions, and hypertonicity of the uterus in and of itself can compromise uteroplacental perfusion, so you really want to think carefully about whether or not you would want to use ketamine as opposed to etomidate. In terms of maintaining general anesthesia when you have a severe abruption, again, this is going to depend on the hemodynamic status of the mother. Now, until the baby is delivered If mom can tolerate it, the use of an inhalational agent may be beneficial in that it may actually help decrease that uterine tone, which is further compromising your uteroplacental perfusion. You need to understand in these situations that fluid resuscitation with crystalloid, colloid, and blood products based on the amount of blood loss and the severity of the coagulopathy will generally be a part of your management of this patient. Now let's move on to the third etiology of antepartum hemorrhage, and that would be uterine rupture. This can be a potentially catastrophic situation, with maternal mortality being somewhere about 1 in 500 cases. Just like with an abruption, the fetus does even worse, with fetal mortality associated with uterine rupture being as high as 6 to 8%. Now, how does a uterine rupture present? Well, there can be all sorts of signs and symptoms. Abdominal pain, vaginal bleeding, mom's unstable. What we talk about is recession of the presenting part, meaning the fetal head had descended and now it's popped back up because the uterus has opened up and the baby is now sitting in the belly. But actually the most common sign of uterine rupture is not abdominal pain, it's not bleeding, it is abnormal fetal heart rate, generally fetal bradycardia. About 70% of uterine ruptures will present with that abnormal fetal heart rate of usually fetal bradycardia. Now, who's at risk for uterine rupture? So any patient who has had a cesarean delivery or any other uterine scar, so if they've had a myomectomy, they would also be at higher risk. Anyone who's had trauma to the abdomen. Inappropriate use of uterotonic drugs, you make the uterus hypertonic, could lead to uterine rupture. And grand multiparous women have a higher risk of uterine rupture just because they kind of have a weak, stretched out uterus as a result of the many previous pregnancies that they have had. Now, we most commonly think about uterine rupture in the patient with a prior cesarean delivery who is in labor, who's attempting a vaginal birth after cesarean. And so what do we know about the data? What is the risk? Because many of us here at UK, we are always attempting VBACs. Depending on where you practice, you may be in the situation where you have patients on your labor floor attempting VBAC. So what is the risk? So it varies depending on various factors. So if you have a patient who comes into your labor and delivery unit, has had one prior low transverse cesarean delivery, and comes in spontaneous labor, the risk of rupture is probably anywhere from 0.7 to 0.9%. Now, if they've not had one, but they've had 2 prior cesarean deliveries, low transverse, then the rate is going to be increased closer to about 2%. We do not let women with a classical or vertical uterine incision attempt VBAC because with that type of uterine incision, the risk of rupture is much greater, probably closer to 10%. Now, I mentioned 0.7 to 0.9% if the woman comes in spontaneous labor. If the patient is undergoing labor induction, her risk of uterine rupture with a VBAC is going to be significantly greater. Overall, it's increased by about 3 times, and that's why you'll oftentimes see the obstetricians reluctant to use oxytocin, to not do an induction, to only attempt a VBAC if the patient's in spontaneous labor. But with low-dose PID, it is a possibility. One thing that you will not see the obstetricians doing is using any prostaglandins as a part of their labor induction, because it has been shown that in the patient attempting VBAC, if you use prostaglandins for your induction, that you can increase the risk of rupture by as much as 16-fold. There has been a push to try to lower cesarean delivery rates in the country, and so one of the ideas has been maybe we should go back to what they were doing maybe 20 years ago, really encouraging women to attempt VBAC, especially if they've only had one prior cesarean delivery. But that hasn't really taken off that much, and why is that? It's because when you look at outcomes, there may be some concern about VBAC, specifically as it relates to the neonate. There was a large observational study of 33,000 women, and they looked at cases of neonatal hypoxic encephalopathy. And what they found was that among the women who elected to have a repeat cesarean delivery before going into labor, there were no cases of encephalopathy. But among those attempting a trial of labor, there were 12 cases, which was a report of a rate of about 0.5 per 1,000 deliveries, and the majority, 7 of those 12, were associated with uterine rupture. So moms, obstetricians may be reluctant to attempt VBAC. Analysis of another administrative database also looked at episodes of fetal hypoxia, and they found that among women attempting VBAC, rates of fetal hypoxia were about 0.89%, whereas those undergoing an elective repeat cesarean delivery, it was only 0.13%. And as a result, an NIH consensus panel looking at VBAC did conclude, as a result of the data from these studies, that the risk of hypoxic encephalopathy is increased with trial of labor. And that is probably a major reason why you will find a lot of obstetricians and patients have no desire to attempt vaginal birth after cesarean. So what does the ACOG and the ASA say about VBAC and uterine rupture, and what do we need to do in terms of facilities and personnel? So there was a joint statement that came out from the two organizations a few years ago, and essentially what they said was, because the risks associated with trial of labor after cesarean and uterine rupture may be unpredictable, immediate availability of facilities and personnel to perform emergency cesarean delivery is optimal. When resources for immediate cesarean delivery are not available, patients should be clearly informed of the potentially increased risk and the management alternatives, meaning that they can have an elective repeat cesarean delivery. And so at a place like an academic medical center like UK, we always have people available. But if you go out into community practice, you will oftentimes see they're not attempting VBACs because they're not able to provide that immediate availability for emergency cesarean delivery. So if you have a uterine rupture, what are our anesthetic considerations? Well, we're concerned about blood loss, so many of the anesthetic implications are going to be similar to that as we've talked about with placenta previa or placental abruption, good IV access, blood available. The other thing to keep in mind, though, is that these patients will require either repair of the uterus, or if it's a very severe rupture, maybe even hysterectomy if the uterus cannot be adequately repaired. And so in many of these patients, if they've been attempting a VBAC, they have an epidural in place, they may be hemodynamically stable, you were able to use the epidural to do the emergency cesarean delivery, but just remember that once the baby's delivered and now they're having to go about doing a repair or hysterectomy, that this is a much more stimulating, complex surgery. And even if the patient has a good block, you may ultimately have to convert to general anesthesia just because the patient is not adequately comfortable under epidural anesthesia with the more involved surgery that's associated with uterine ruptures compared to just a routine cesarean delivery. So now let's move on to postpartum hemorrhage. This is a significant problem. Worldwide, it complicates about 5 to 10% of all deliveries. Somewhat lower in the U.S., about 3% of deliveries. However, what is concerning is that it does appear that the rate of postpartum hemorrhage is increasing in the U.S. One study that used the nationwide inpatient sample, which gives you administrative data for many, many deliveries throughout the country, they looked at rates of postpartum hemorrhage from the period of 1995 to 2004. And they found that overall the rate of postpartum hemorrhage had increased by a little over 27%. And primarily this was due to an increase in episodes of uterine atony. And concerning, they found that in terms of looking at maternal deaths post-delivery, that postpartum hemorrhage was associated with about 20% of those maternal post-delivery deaths. So it is a significant problem that we need to be aware of and ready to manage. Then that was just looking at postpartum hemorrhage. And then there was another study, again, using the nationwide inpatient sample, more recent from 1999 to 2008, that looked specifically at what they defined as severe postpartum hemorrhage. And they found that the rate of severe postpartum hemorrhage had doubled over that 10-year period. And unlike the previous study, this was found to be increases in both atonic and non-atonic causes of postpartum hemorrhage. The etiologies for these studies finding increases in increasing rates of postpartum hemorrhage isn't well understood. When they looked at known identified risk factors for postpartum hemorrhage, they could only determine that about 5 to 6% of the increase was associated with changes in the population in terms of the number of people with those identified risk factors. One thing that they did find that there was clearly an association between non-atonic causes of postpartum hemorrhage and cesarean delivery, which suggests that placenta accreta and other abnormal placentations are a contributing factor to this increase that we're seeing. And that is not surprising because as we talk a little bit later about abnormal placentation, placenta accreta, we will find that the risk for that problem increases with previous cesarean delivery, and as nationally we've seen a continuing rise until the last couple of years in cesarean delivery rates, one might expect to see a higher rate of these abnormal placentations. So what are risk factors for severe postpartum hemorrhage? Because the reality is, as anesthesiologists, those are the ones we're most concerned about, is the severe postpartum hemorrhage. Those are the ones that may require some sort of anesthetic intervention that are at higher risk for significant morbidity and even mortality. The patient with a postpartum hemorrhage, uterine atony after a vaginal delivery who has just 500 cc's of blood loss is probably not going to be a really big problem for us. So we're especially interested in those with severe postpartum hemorrhage. And what has been found is risk factors include older maternal age, multiple gestation, preeclampsia, chorioamnionitis. It's well known that the infected uterus does not contract as well. Patients who've had instrumented vaginal deliveries, forceps or vacuum. Cesarean delivery is associated with a higher risk of severe postpartum hemorrhage. And in terms of identifying patients, if you look at their labs, it's also been shown that women with a fibrinogen less than 200 are at significantly higher risk of developing severe postpartum hemorrhage. What are the etiologies? Uterine atony is the most common one. As I mentioned, placenta accreta and other abnormal placentations such as placenta increta and percreta are major causes. Also, you can have vaginal or cervical lacerations that can cause significant blood loss, retained placenta, and uterine inversion or other etiologies. In terms of uterine atony, that is the most common cause of postpartum hemorrhage. Risk factors include age, either being young or old, cesarean delivery, chorio, as I mentioned. Patients with antepartum hemorrhage, especially placental abruption, also have a higher risk of postpartum hemorrhage, uterine atony. Those with an overdistended uterus, so that's the patient who's got multiple gestation or big-time polyhydramnios. If they have retained placental parts, fragments of placenta, they're going to be at higher risk for atony. And preeclampsia also has a higher risk of uterine atony, may be associated with the fact that they're on magnesium sulfate. But the reality is most women who develop uterine atony don't have any risk factors other than having had a cesarean delivery or their age, but most don't have chorio, they don't have an overextended uterus, but they still get uterine atony. Now, in terms of treating uterine atony, the number one, the first line is uterine massage, which is going to be done by your obstetrician or labor and delivery nurse. Next, we go to pharmacologic therapy. So the first line drug is going to be oxytocin. This works by stimulating both the frequency and the strength of contractions. And late in pregnancy, the uterus has increased receptors to oxytocin, so it's going to be more responsive rather than early in labor. I mean, early in pregnancy, not labor, or in a non-pregnant patient. In terms of dosing oxytocin, generally we avoid boluses, at least boluses of 5 units or greater, because a bolus can produce peripheral vasodilation leading to hypotension. In most cases, we're using 20 units in about a 500 to 1,000 milliliter of IV crystalloid and running it at an infusion of usually 100, 150 milliliters per hour. Methergin, which is an ergot alkaloid, is a second-line treatment for uterine atony. It works by increasing both the frequency and the force of contractions. Things to be aware of with Methergin is that it is a potent peripheral vasoconstrictor. So unlike oxytocin, where you get vasodilation, with Methergin you will see significant peripheral vasoconstriction. In patients who already have hypertension, be it a chronic hypertensive or a patient with preeclampsia, it's been reported that they may develop severe hypertension and bradycardia if you give them Methergin on top of that. There have been cases of stroke and cerebral edema and coronary vasospasm when the drug has been given intravenously. So this should be a drug not given IV, but rather given intramuscularly. Or occasionally you may have an obstetrician choose to give it into the uterus. Things to be aware of is that if you have given methogen after a patient has received vasopressors, you may see a rebound hypertension. If you do have severe vasoconstriction, you want to use a vasodilator to treat that, so nitroprusside or nitroglycerin. The dose of methogen is generally going to be 0.2 milligrams given IM, as I mentioned. Another second-line drug for uteranatomy is 15-methylprostaglandin F2 alpha. That's a really long name, otherwise known on labor and delivery as Hemabate. It works by increasing the strength of contractions, and it can be given either IM or right into the myometrium. Adverse effects first, the most common concern is bronchospasm, so it's relatively contraindicated in those patients who have asthma. Also, it can increase your pulmonary artery pressure, so it also should be avoided in patients with pulmonary hypertension. Not as severe of a problem, but certainly a common adverse effect is that these patients can get significant diarrhea. I actually had one patient who, while they were still in the operating room, she had gotten Hemabate, got really massive diarrhea with concern about contaminating the surgical field as a result. So that is another adverse effect. Another prostaglandin that is being used as a second or third line drug is that of misoprostol, which is a prostaglandin E1 analog. It is administered rectally, usually 800 micrograms. It is something to think about. Oftentimes, the obstetricians will use it in addition to a second-line drug like methogen or Hemabate, or if they have someone that they don't want to use Hemabate because of asthma, you don't have that bronchospasm effect with this prostaglandin E drug, and so that would be a time when you might use it also. Now, if you've treated the uteranatomy pharmacologically and have been unsuccessful, the patient's continuing to bleed, has a floppy uterus, now the obstetrician is going to be moving to some sort of invasive management of postpartum hemorrhage. And this may include a D&C, especially if they feel that there may be some pieces of placenta left that's contributing to the uteranatomy. Intrauterine balloon tamponade is being used more and more. That is the Bakri balloon that we see our obstetricians using. If they go to surgery, they're doing a C-section, or they've, everything else has failed and they decide they might actually even have to do a hysterectomy, what they might first try to do once they open up is a B-Lynch compression suture, which is depicted here in this slide. I'm not sure why that says approaches to hysterectomy on the slide, because that is actually an example of a B-Lynch compression suture there. I guess that's actually, I'm sorry, that is the title of the book from which this particular picture was taken. Arterial ligation, so that is a way to go about trying to control the bleeding in avoiding hysterectomy. Or rather than surgical ligation, you may also get your interventional radiologist involved and do an embolization. That can be effective in treating the postpartum hemorrhage of uteranatomy, but ultimately, if all else fails, in order to save the life of the mother, you may have to proceed to hysterectomy. For these invasive techniques, in terms of anesthetic management, it's like any other case, really, where there's major bleeding going on. So you want good large bore IV access, a couple of good 16 gauge IVs. If you can't get that peripherally, then consider a central line. Fluid and blood resuscitation is important. Make sure that you're getting blood. This is something that I would say most of our patients have a type and screen. When you start seeing that you're running into significant uteranatomy, one of the things you want to do is make sure that that type and screen gets converted to type and cross, so you'll have blood available. In terms of your anesthetic choice, it's going to depend on maternal hemodynamic stability. Sometimes you can do a regional, especially if it's, say, they're going to do a D&C because they think the bleeding is related to some retained placenta. Mom has not bled so much that she's unstable yet. If you're reaching the point, though, where you're talking about doing a hysterectomy, in that case, you've probably had major blood loss and mom is probably not that stable, and then you would probably need to use a general anesthetic. One thing to keep in mind, if you are doing a general anesthetic in a patient, say for cesarean delivery or for postpartum hemorrhage, remember that your volatile anesthetics can interfere with obtaining adequate uterine tone. Now, most of what we know about the effect of volatile anesthetics is related to in vitro studies of malmetrium. But what studies have found is that there is a dose-dependent decrease in both the strength and duration of contractions that are induced by oxytocin. So the more volatile agents you give, the greater the effect on uterine tone. Once you get up to about 2 MAC of a volatile agent, you will have complete inhibition of any oxytocin activity. You can give as much Pitocin as you want and you won't see any effect. Another important thing to understand is that the pregnant malmetrium is actually more sensitive to the inhibitory effects of your volatile agents than a non-pregnant uterus. Also, if you're trying to decide which volatile agent to use, if you need to use a volatile agent in this setting, that has been shown, at least in vitro studies, that desflurane causes less inhibition than sevoflurane. But what I would say is that if you're in the setting of severe uterine atony that's not responded to anything and you're under general anesthesia, probably the best thing to do is to turn off your volatile agent and go with a TIVA. Now, nitrous oxide is not going to affect your uterine tone, so you can maintain nitrous oxide, opioids, propofol, and just try to get rid of your volatile agents. Now let's talk next about abnormal placentations. Most commonly, it's a placenta accreta, which is where the placenta is adherent to the malmetrium. You try to separate it, and you just precipitate a lot of bleeding. It will not easily separate from the uterus. An increta is where the placenta is actually grown into the malmetrium, and it's even more difficult, if not impossible, to separate that placenta. And then a percreta is the most serious, which is where it's gone through and through the uterus, through the serosa, and out into the abdomen, and oftentimes may also be growing, the placenta may be growing into other pelvic structures, most commonly the bladder. So what do we know about placenta accreta in the U.S.? We know that as the rate of cesarean delivery has increased in the U.S., we've also seen an increase in the rate of placenta accreta and other abnormal placentations. So back in the 1960s, the incidence of placenta accreta was about 1 in 30,000 deliveries. We're now up to 1 in 333 was the most recent estimate. And obstetricians pretty much feel that this is really due to the significant rise in cesarean delivery rates that has occurred over the past many years. We also know that there is clearly an association. So with placenta accreta and previous cesarean delivery, and specifically a big red flag to you should be any patient who presents to your labor and delivery unit with a placenta previa and a previous cesarean delivery. This significantly increases the risk of a placenta accreta. So just having a placenta previa actually increases the risk of an accreta. About 5% of women with just a placenta previa, no prior cesarean delivery, will have a placenta accreta. If they've had cesarean delivery, it's greater, and as the number of cesarean deliveries increases, the risk increases. So some of the most recent data I found, placenta previa and 1 cesarean delivery, about a 10% risk of placenta accreta. If you get up to 2 cesarean deliveries now, in conjunction with a placenta previa, about a 40% risk. And 3 or more cesarean deliveries and a current placenta previa, 60% or greater risk. So these patients should be a red flag to you. Do they have an accreta? What am I going to do to be prepared for that? So in terms of management of placenta accreta, you need to be prepared for massive rapid blood loss. Now, with ultrasound, obstetricians have become much better about identifying placenta accreta in advance, and that is good because some of the most massive blood loss you will get is when you try to separate the placenta, not realizing that it's an abnormal placenta that is adherent to the uterus. So generally, if the placenta accreta has been identified as being present, what is usually planned now is delivery of the baby. via cesarean delivery, and then going immediately to hysterectomy. In that case, you won't have generally as much blood loss, but understand that a gravid hysterectomy is much greater blood loss than a routine hysterectomy done in a GYN patient. So even with a placenta accreta where they decide to go straight to hysterectomy, they don't mess around with trying to separate the placenta and stir up a lot of bleeding there, you still will see significant obstetric bleeding. So these patients need 2 good large bore IVs. Definitely I consider an arterial line, may consider a central line, especially if I'm not really confident in my peripheral IV access. I will not start these cases until I have blood in the room ready. So some things to keep in mind. In terms of your choice of anesthetic technique, this can be controversial. It's actually been topic of debates, formal debates at OB anesthesia meetings in the past. Some people will go ahead and do epidural anesthesia or neuraxial anesthesia. They say, it avoids the risks associated with general anesthesia that we know are significant in parturient. And there was a retrospective study that reported no increased morbidity no increase in morbidity or blood loss when they did no increase in maternal morbidity and actually less blood loss in those in this retrospective study who had the procedure done under neuraxial anesthesia as compared to general. However, I would say, remember, this is retrospective, so probably what happened was with those who seem by ultrasound, etc., to have a really significant, extensive accreta or increta, percreta, probably they didn't attempt to do that under regional, but rather did it under general. And of course, you're going to expect more bleeding in those patients. Myself, I generally advocate for general anesthesia in the majority of these cases, especially if it's a definitely identified accreta where the obstetricians are already planning on their gynecologic oncologist to be there to help them and to go directly to a hysterectomy. I prefer to have general anesthesia. Sometimes you will have obstetricians and patients asked to start out with neuraxial with the plan, if need be, to convert to general. If it looks like it's a very small accreta and they expect that they're not going to have to go to hysterectomy, it's not going to be that much more blood loss. But although there's always that potential, I may consider starting under regional, but usually I'll go straight to general because if I do neuraxial, I have now a significant sympathectomy on board, and then we run into massive blood loss. It's going to be much more difficult to resuscitate that patient with a major sympathectomy on board. So that's one reason why I like general anesthesia. Also, generally it's going to progress to hysterectomy. That is a more complicated surgery in which the procedure done under neuraxial anesthesia. So just for patient comfort, you might have to convert anyway. So in most of these patients, I choose to start with general anesthesia from the start. Now, so we've gone through the most common causes of both antepartum and postpartum hemorrhage. And now I just wanted to talk about some of the newer things in the management of obstetric hemorrhage, regardless of the etiology, that may help us in terms of getting better outcomes in these patients, since we have identified that it is a leading cause of maternal mortality even in the developed world. So I'm going to talk some about massive transfusion protocols. Is there a place for intraoperative cell salvage in OB? Talk about obstetric hemorrhage bundle, which we are starting to implement here. There have been some data looking at the use of fibrinogen concentrate and tranexamic acid in obstetric hemorrhage, with authors reporting some good results, but really there's not good evidence out there yet to support any sort of routine use of either of these products in the setting of obstetric hemorrhage. It's mostly been smaller case series that have reported better outcomes, either in terms of maternal morbidity, avoiding hysterectomy, etc. So in the setting of severe obstetric hemorrhage, patient is unstable, you've tried just about everything else, and patient is still bleeding, certainly in that sort of it might be a last-ditch effort is to try using fibrinogen concentrate or tranexamic acid, but to use it routinely in obstetric hemorrhage, we're not there yet in terms of the evidence to support that. It may be that we ultimately get there, but not yet. And then also arterial embolization is another way of managing obstetric hemorrhage, where you can also sometimes preserve the uterus and the patient's fertility. So in terms of massive transfusion protocols, we're all familiar with these, primarily in our trauma patients. The first data came from the military, where they found that using lower RBC to FFP and RBC to platelet ratios during massive transfusion, that there were improved outcomes in their soldiers. And so from there, studies were done in civilian trauma patients, and again, studies that found using things like 3:2 packed red blood cells to FFP and 5:1 packed red blood cell to platelets were associated with decreases in many outcomes: pulmonary failure, sepsis, multi-organ failure, and ultimately mortality. And so based on these studies, more and more places have developed massive transfusion protocols. As they have evolved, we've come up with simpler protocols, which have shown also good outcomes and probably easier to implement. So many of our massive transfusion protocols now are using a 1-to-1-to-1, 1 unit packed cells to 1 unit FFP to 1 unit FFPs when you're anticipating massive blood loss and massive transfusion. What about in OB? There's limited data on the use of these protocols in OB, but certainly we are using massive transfusion protocols. There can be special challenges in the OB setting in terms of getting blood available. The other thing to keep in mind is that the etiology of obstetric hemorrhage is quite different from hemorrhage in the trauma patient, and so we may need to have some fine-tuning of our massive transfusion protocols. And actually at one institution, they did develop a specialized protocol for obstetric hemorrhage, which is shown here. And the thing that I will point out is, as we mentioned before, the patients with a low fibrinogen level is a risk factor for severe postpartum hemorrhage. And you will find in many of these obstetric patients, especially those with abruption, that they have a very low fibrinogen. And so in this specific OB massive transfusion protocol, the one thing that differed from your usual massive transfusion protocols is that they included cryo early in their very first round of products, and they included cryo in every round of products. So that's something to keep in mind. Our massive transfusion protocol here at UK does not differ for OB patients, but you may want to consider, if you activate massive transfusion protocol in OB patient, to also ask the blood bank to start giving you cryo with your first round of products. Now, what about intraoperative cell salvage? Now, in the past, there were concerns about using it in the OB patient because in terms of salvaging that blood, you also has amniotic fluid that it may also be mixed with the blood that you are salvaging. And so there was concern about, am I going to precipitate an amniotic fluid embolism? Also concern about maternal isoimmunization from fetal RBCs, because clearly, especially in settings of trauma, abruption, there is contamination with fetal RBCs. However, it's been used more and more. There's now more than 400 cases reported in the literature of using intraoperative cell salvage without any serious adverse maternal effects. And so in the setting of massive hemorrhage, I think it is reasonable to consider using cell salvage. Also, it's reasonable to consider having it available in patients who maybe are at risk for significant obstetric hemorrhage but refuse blood products, primarily your Jehovah's Witnesses. Now, in terms of the techniques for cell salvage, it is definitely important to make sure that in the blood washing that you include a leukocyte reduction filter. It was found that when the leukocyte reduction filter was added in terms of washing blood from obstetric patients, that they were able to reduce squamous cell contamination of the blood to the point where the amount of squamous cell contamination was similar to that of what you would find if you just drew blood from a mother, just drew maternal blood, a blood sample. It was very similar. Now, one thing that the leukocyte reduction filter does not do, and you would expect this, is that it cannot decrease the contamination of fetal red cells. So if you do have a woman that receives cell salvage blood and is Rh incompatible with her fetus, that mother will definitely need to get later maternal anti-D immune globulin to prevent future problems. So in terms of, cell salvage and obstetric hemorrhage, the reality is the safety of the technique now seems to be better established. Many recommend its consideration in severe hemorrhage. Massive, if you're having to institute massive transfusion protocol, you might consider using it. Some, in other countries at least, have actually reported implementing it routinely on their unit in patients who are at risk for hemorrhage, with the goal actually of minimizing the amount of homologous blood transfusion that needs to be given. I not know of anyone in the U.S. that's done that yet, but over in the United Kingdom, there are units that are doing that. If someone, has placental abruption or some other, risk factor for, placenta Accreta, for instance, they will routinely set up cell salvage to use in those patients. Now, what about in the setting of amniotic fluid embolism? Because as we will learn in a future talk, with amniotic fluid embolism, these patients are at increased risk for DIC. A significant number of them will develop DIC, and so they may have major postpartum hemorrhage. And so would you use cell salvage in that case? Well, my recommendation is just don't do it, because there's, although cell salvage blood seems to be safe, and we've seen it used in hundreds of patients without any problems of amniotic fluid embolism precipitated by the blood that has been salvaged. Those were in normal patients, not those with an amniotic fluid embolism, and it has been suggested in terms of the etiology of amniotic fluid embolism that women who develop it, there's something abnormal about their amniotic fluid. And this was a case report. I think it was gutsy to do this and to publish this, but this was a case of a patient with DIC in which it was presumed that she'd had an amniotic fluid embolism, that was the etiology of her DIC. And they had been resuscitating her, and she'd become stable, but they'd, lost quite a bit of blood, and they had done cell salvage, and they decided to give her some cell salvage blood after resuscitation had allowed her to reach a point of hemodynamic stability. Almost immediately after they gave her that cell salvage blood, she again became severely hypotensive and hypoxemic, suggesting amniotic fluid embolism again. So that is the one setting where, even in the setting of massive transfusion, if I'm concerned that the etiology of my bleeding, my coagulopathy may have been an amniotic fluid embolism, I would not use cell salvage in that situation. Arterial embolization, as I mentioned, can be a way to control obstetric hemorrhage with your radiologist. Uterine artery or intrailiac is the artery that usually will be embolized, and it's been shown to in many patients, be effective at controlling hemorrhage. And oftentimes it's used as a way to try to avoid hysterectomy. Maybe you have a young 21-year-old first baby, massive postpartum hemorrhage, and nothing has worked, and you're talking about having to maybe do a hysterectomy, but you say, let's get the radiologist involved. And there have been many case series where they have been able to show that using embolization can control hemorrhage, can avoid hysterectomy. And another concern may be, well, you're essentially cutting off the blood supply to the uterus. What we know is that these women do develop collaterals, and fertility has been maintained in some patients, and there have been reports of subsequent pregnancies after doing an arterial embolization in the setting of obstetric hemorrhage. In one case series, they reported a success rate greater than 90%, and in all sorts of etiologies of hemorrhage. Patients with abnormal placentation, patients with uterine atony, patients with major cervical laceration, and also in patients who continued to bleed post a hysterectomy. It was successful in treating the hemorrhage. So something to consider. There are logistical issues, though. That is the greatest barrier to its use, and it's really, for a while it was being used more frequently, but I think as we've started being maybe more effective at things like our massive transfusion protocols, keeping up with blood loss, etc., or using things like Bakri balloons, we are not doing it as often. But the biggest issue logistically is, coordinating your obstetrician, your anesthesiologist, your radiologist, your staff on both labor and delivery and in the radiology suite, getting the patient who's oftentimes unstable transported to your interventional radiology suite can be a barrier. So these are things to consider. And also from an anesthesia standpoint, it's a challenge. Ways that you may improve these logistical issues is in those patients who are at high risk. You know they have a placenta Accreta, for instance. You may actually contact your radiologist ahead of time, and people have reported actually putting prophylactic femoral artery catheters in so that if they do run into the bleeding, they don't have to get access. They've already got access. They can rush her to the radiology suite and go ahead and identify a vessel and embolize it. And there's actually at one institution, they've even reported in these high-risk patients doing the cesarean delivery in the radiology suite so that if they run into major bleeding, they have their equipment right there. They don't have to transport the patient, and they can go ahead with their embolization immediately. But I can tell you, as you all know, if you've done safari cases, that a big challenge for us as anesthesiologists is that we're in an environment we're not as familiar with all this radiology equipment in our way. It is a real challenge anesthetically, but it may be a way to save a mother's life or to save her fertility by doing an embolization. And then finally, so we've mentioned obstetric hemorrhage, even in the United States, continues to be a leading cause of maternal mortality. So how can we improve? How can we get better outcomes? Well, one idea that's out there is to have an obstetric hemorrhage bundle, and this has been a national project that there was a group put together, the National Partnership for Maternal Safety, brought in obstetricians, anesthesiologists, blood bank specialists, nurses, etc., and developed this obstetric hemorrhage bundle that they recommend that every obstetric unit in the United States develop. And we are in the process of, we have much of this on board already here at UK. The rest of it will be starting soon. So for instance, having a hemorrhage card, the nurse educator on the unit has been working for a long time getting that all put together and ready so that anything you might need in terms of supplies like Bakri balloons, etc., are right there. You don't have people running around trying to find all the equipment that you need. Having immediate access to hemorrhage medications, which we do. We know where those are kept. Having a response team that includes, getting the blood bank involved early. Notifying your gynecologic surgery colleagues from the standpoint of the obstetricians, getting people available that we need. We, of course, already have a massive transfusion protocol. And then what's going to be a big focus beginning for us in July is very major education to residents, nurses, and doing some drills on the unit, some simulations. So that's being ready. And then with every patient now, there's going to be a system with nursing and obstetricians of assessing every patient for their risk, both prenatally before they come to labor and delivery, during admission, and then throughout their time on the labor and delivery unit. There's going to be more of a focus on being more accurate in our estimation of blood loss. They're going to be getting special drapes for vaginal deliveries that are calibrated. We're going to be doing more careful assessment of laps and such in our labor, in our C-sections to identify our blood loss. Active management, third stage of labor, something that's already done here at UK. And then another part of the bundle is just the response for every hemorrhage, having a standard way of doing that. And that is part of having the hemorrhage card and the education. And then looking at our outcomes, doing things like debriefing afterwards. And as you know, we do swarms when we have big events such as a massive obstetric hemorrhage. And then our perinatal quality and safety committee is already monthly looking at our metrics related to obstetric hemorrhage. So this is something, much of this obstetric hemorrhage bundle we are already doing on our labor and delivery unit. The rest of it will be implemented within a few months, and it has been a national initiative. And I think that this is one major way in which all of us can help improve outcomes for women with obstetric hemorrhage. And that is the most major problem of pregnancy and delivery that you're going to confront as an anesthesiologist, and I hope this has helped you get good information about how what to be prepared for and how to manage these patients. Thank you.